Welcome, my friends, to the Bob and Brad podcast. My name is Mike Kienitz, and today I am interviewing Dr. Avi Bhar, who is a sleep medicine and pulmonary medicine specialist. Today, we are going to be talking about restless leg syndrome, what it is, some common risk factors for developing it, and some treatment options as well. So, without further ado, here is Dr. Bhar. Well, welcome to the podcast, Dr. Avi Bhar. Thank you so much for joining us today.
It's good to be back, Mike.
You are a three-time repeat guest. You're tied for second right now, so maybe we
Oh,
can get you in
nice.
first after a while.
Done deal. Challenge accepted.
So we are going to be talking about restless leg syndrome today, but before we get into that, would you mind telling our audience a little bit about yourself?
Yes, thank you for that opportunity. I'm a sleep physician. I'm a board certified sleep physician and fellowship trained. I've been in practice, that's old, a little over 10 years now, 11th year into it, and have had a great few years. I mean, I started off as a pulmonologist and a critical care physician, did my sleep fellowship, which completed in 2013, and I've been in practice since. And the more I do sleep medicine, the more I like it. I think it serves a huge unmet need because just the experience or knowledge about sleep hasn't been there, and so it's kind of cool to delve into a really new field. And this conversation today is about restless legs, so it's also something that I see frequently being mismanaged out in the community. And so I'm glad to be here. And part of what I do is we are a virtual sleep practice that manages sleep care virtually. Everything that we do is online via telemedicine visits and so on. If any testing is required, we will arrange for that as well, closest to the patient's home. If they need an in-lab study, we will also do that closest to the patient's home. Because one thing I've learned after coming out of fellowship is that care is not distributed evenly, and it really depends on your zip code. And I'm not even talking about simple things like in a city in a different zip code. You can be just in the same area, and you may not have adequate access. I mean, you could have some places that are right outside cities that can't get access to good sleep physicians. Period. So it is necessary for us to at least be able to reach patients where they need us and when they need us. But thank you for that opportunity introducing myself.
So, do you mind mentioning your website and what states you work in currently?
Yeah, we are in 12 different states. The website is sleep.com, and it's a patient of mine thought it was crazy. She actually said, I don't know how you crazily spell this word. And I was trying to explain to her as the cheapest way to buy the word sleep, but cost apparently wasn't a factor. She says, you should just bought sleep.com with two E's, but it's actually SLIIP.com, just to save us on the $1 million that sleep.com would have cost otherwise. We're 12 states right now and growing, expanding. Connecticut, New York, Virginia, South Carolina, Kentucky, Illinois, Georgia, Florida, Mississippi, Alabama, Louisiana, Texas. We are expanding into Oklahoma, Arizona as well. So looking to expand even further and coming to New Jersey as well in the coming few months.
Sure. So, we're going to get into the topic at hand here. So, restless leg syndrome, what is it and what are some of its primary symptoms?
So it's primarily a neurological disorder that occurs prior to sleep. It doesn't occur. It does occur in a different form during sleep itself, but it's a frequent offender in causing patients not to be able to fall asleep because of the restlessness in the legs. There's many theories out there about what sets it, causes it. It is definitely something that's triggered by a lot of things. But it basically is a sensation, an odd sensation that you get in both your legs, or it could be in either one, maybe one predominant over the other. Generally, not just one-sided, meaning that you have only one leg symptoms and the other leg is completely fine. It doesn't really occur that way. It might alternate between one and the other leg, but it doesn't just occur on one leg and not the other leg, like absolutely. It is something that occurs mainly at night when you're sedentary or when you're sitting down. If we're in a movie theater, if people know what that is, or sitting down that sofa at night, it tends to, or when they lie in bed. It's categorized by different words. Some people describe it as painful is not a common word, but it is used to describe it. It is also uncomfortable, creepy, crawly. I have like a million ants on my legs. I just can't get comfortable. So these are all different terms used to describe the sensation in the legs, and that stops them from staying comfortable. Hence, they need to move their legs, and the movement itself or rearranging of their feet and leg and moving back and forth alleviates the symptoms temporarily, and then it tends to occur again. That's kind of basically a nutshell of what restless legs in evening, when sedentary, categorized by odd sensation, awkwardness, uncomfortable legs, and then partially relieved or temporarily relieved with movement.
Sure. So, how do you diagnose it?
It's exactly the four criteria. You have to kind of go to the list to make sure that the patient does have it. Now, again, could you have restless legs in the daytime? Yeah, you could, but generally it starts off at night and may progress to the daytime for various reasons, but it primarily occurs in the evening. And so the four criteria, again, if you have an odd sensation in your legs, temporary relief by movements, mainly at night, and it's something that happens when you're also sedentary or not moving around.
Sure. So, are there like different types or severities of it?
Severity, yes, there's the mild, moderate, severe, and really it's based on symptoms frequently. So patients usually start off with some mild form, and then one thing that may cause is one thing is lesser known is the cause of augmentation or the worsening of symptoms because of the medications that we were or have been using that might cause that. But there might be a progression as well as patients leave it be and maybe try different alternative therapies. So it might progress over time or it just remains about the same. So some people don't necessarily progress to worsening of their restless legs. It just continues to bother them. So there is the categorization of mild, moderate, severe, especially when it comes to how badly it affects them from being able to fall asleep.
So, there's not any real hard evidence of a known risk factor, but can you talk about some of the risk factors that are often associated with developing it?
Yeah, so one of the most common ones is pregnancy is one of them. Women tend to develop that in pregnancy, makes their sleep even worse. It's already uncomfortable to sleep with a growing baby in your belly. And then add the fact that you have that renal dysfunction as well. So kidneys, if your kidneys are not working well, low iron levels as well may trigger that. A family history of restless legs can put you at increased risk of that. And those are kind of the more of the what we call primary restless legs. So it's something that there's no causative agent. It's either in your genetics or some form of life change that may have triggered that. But then there is a lot of secondary restless legs that occur because of medication use and lifestyle choices and so on that might trigger that. Even stress during work and so on that might be on the secondary side of restless legs.
Sure. Yeah, I was reading so I could actually know what I was talking about a little bit today. So I did see peripheral neuropathy, there's a correlation, and if you had anesthesia to the spinal cord at all during any surgeries, I believe would
Yeah,
also be.
and I'm glad you mentioned that. So that's why I was kind of making the point about the leg symptoms not being one-sided versus both sides. Because if it is mainly one-sided, there might be a more of a spinal involvement in the issue, and so things like sciatica and so on. That those kind of things that go down one-sided and primarily one-sided are not consistent with restless legs. So it can be related to some sort of spinal issues. Now, anesthesia may cause that, but again, if it causes bilateral, I definitely seek some follow up and not just leave it to medications to treat that because it might be something more ominous going on that may be procedural related or back pain related to your spine. So that's why if it's on one side and if you have a procedure that was done recently, you need to go in and have that checked out.
Is there, I was reading and it said it's not known, but they're finding a link between lack of dopamine release when you're sleeping. They're finding a correlation between that too. I don't know if you've heard that or
Mhm.
not, but
Well, it's that is the basis of the disease, and that's kind of where the initial use of drugs like dopamine agonists have were the first ones tried because of this underlying pathophysiology of the dopamine release. And so, dopamine agonists such as pramipexole, along with Requip or ropinirole were frequently used. Initially, started off with levodopa, which is drugs that a drug that's used for Parkinson's, and so that these drugs, along with a patch form of a dopamine agonist called rotigotine, are dopamine agonists, which is to treat the underlying problem, which is the release of dopamine. However, we find that the use of these drugs seems to cause, or at least lead to, short-term improvements, but with a long-term price to pay for a phenomenon called augmentation, where the drug itself over time will cause worsening of your symptoms, and it makes it harder to manage these symptoms down the road. Even if you take the drug away, it has to be weaned down very gradually, but then it also it may stick around. The augmentation may stick around a lot longer. And sometimes some people have persistent augmentation despite stopping the medication. So the underlying pathophysiology is related to dopamine, a lack of dopamine release, but the dopamine agonists have had a very, I think recently as well with data, now we know that it probably is not an agent to start off with. Previously, it was the first line of therapy.
Sure. Huh. Interesting. I'm learning stuff today. So, are there any certain populations or demographics that are more prone to developing restless leg syndrome?
They are, but I think the demographic population really is. I think in terms of their medical issues, genetics wise and so on, we know that there's a predisposition to certain groups. But what we've seen in our clinic as well is all comers and all ages, especially in older folks, honestly. But the usual confounding factors are patients who have current sleep issues, peripheral neuropathy, like you mentioned, if they have diabetes and so on, again with the renal dysfunction, along with patients who are going through pregnancy and so on, a family history of that.
Sure. Yeah, and you did mention Parkinson's. I saw that was a common
Yes.
thing, which makes sense. I mean, it's a neurological disorder, so I see how it affects it. So you talked about restless leg syndrome. Most people feel it when they're going to sleep and they
Mm-hmm.
can't fall asleep. But you mentioned it can affect you while you're sleeping. How does that work? I read some people kick and stuff during their sleep.
Yeah, and it's usually once you do the sleep related movement, it's called periodic limb movement disorder, or disease. And so that, it's a fine line, and it's not something that I would say that needs to be an important aspect of things. But we know that it might cause disruption of your sleep during sleep itself. But generally, restless legs is a diagnosis made when someone's awake and trying to fall asleep. But there's another form of it, which is known as PLMDs, or periodic limb movement disorder or disease, that might disrupt your sleep further during the night as well. And that causes that fragmented sleep, that waking up feeling unrested. And we know as well, restless legs, whether associated with the PLMDs or not, increases your risk of heart disease and so on,
Sure.
and reduces your quality of life significantly.
So, from what I understand and just knowing people, this can kind of happen at any age.
Yes, it can. And I say this without hoping to kind of be negative about certain issues, but there is, these medications I mentioned, the dopamine agonists, for example, are very easily now attainable and used by primary care doctors, and because they're marketed to fix the restless legs with this, patients tend to get these medications when they shouldn't. There's ways that you need to work up patients with restless legs that actually ends up being much better in terms of outcomes, meaning that the patients may not need treatment, because kind of what I was describing earlier, the primary and secondary. If you have someone with restless legs, the first thing to do is to rule out other inciting factors, because if you rule out a triggering factor, it may avoid the patient needing a medication in the first place. Now, that being said, there are patients who come to us that are really severe, and you're like, okay, while I figure this stuff out, I was going to use a different word, but once we figure that stuff out, we can give you the medication, short-term medication, to kind of just ease your symptoms so that you can get some sleep. But if you do have time on your hands, and a lot of these are chronic issues that have been going on for months or years before patients seek help. So, we normally will do a diligent workup, and that includes simple things like looking through the medication list. Common offenders are antihistamines, medications that are used for allergies, like your Benadryls and your citrazines or Allegra and so on, which may trigger restless legs. Antidepressants or specific groups like SSRIs may trigger restless legs as well. Antipsychotics like Seroquel or quetiapine and the other antipsychotics in that group may also trigger restless legs. So trying to look at these factors, low iron levels can trigger uh, uh, restless legs, because iron is also a cofactor in the development of dopamine, which is now reduced in the system. So you're trying to augment the system, and don't get that confused with augmentation. You're trying to augment the system so that it's able to do what it needs to do, and you don't have anything else fanning the flames of that, which is the medications that you may have. Then the other thing that we look at is lifestyle choices, things like whether smoking is a big part of your life and what you're doing. And if that's the cause, then we need to kind of evaluate that as a need to reduce. Of course, it's easier said than done, whether it's smoking, whether it's alcohol, and so on. We know these are long-term things that are hard to kick, habits that are hard to kick. But it comes down to whether you feel the pain of actually of having this disease. Is it worthwhile actually keeping up with the smoking as much and the alcohol use, because we know these are triggers. Other triggers that commonly occur are also things that occur in your sleep. So you could have sleep apnea, for example, a breathing disorder, which fragments your sleep, causes surges in stress or stress responses, and that can trigger restless legs as well in patients. So frequently patients who have a lot of restlessness in their legs prior to sleep, during sleep, and so on, improve once you treat what may be another inciting factor, which is another sleep disorder. So trying to ensure that all of these factors are looked at first before we jump to therapy is extremely important, because again, you might actually help the patient by avoiding them needing medications. And then if you do your due diligence and you check your iron levels and so on, and one of the things that frequently doesn't get looked at is the iron levels. And the two things that we're looking at is serum ferritin level and total what's called TSAT, or what is known as transferrin saturation of more than 20%. So you need to have those. And the reason this is important is because the normal cutoff for this is a lot lower. So if a general physician were to look at your iron levels and everything would look normal, they would show all green on their medication, on the lab values, on their electronic medical record system, because all is normal for the general population. But we know that specifically because iron is an important cofactor for dopamine, and we need iron to get into the brain to actually then help with dopamine production, it does need a slightly higher elevated serum level or blood level to cross the blood-brain barrier. And so sometimes when a physician looks at it, oh, it looks normal, there's nothing to treat. But obviously in the hands of a sleep physician, we know that the cutoff is 100 nanograms per deciliter, along with total serum nanograms per milliliter, and a total saturating level of transferrin saturation of 20%. So these are criteria we look at. And if they do have those iron levels low, we need to supplement that. And usually, depending on the severity, we can go with either an oral iron supplement, or we can try an IV iron supplement to actually increase the levels a lot quicker, depending again on the level of severity. Something's mild, we can try long-term or oral medications and then retest the level in 3 to 6 months. But sometimes patients are severe enough that they require the iron infusion, and that's to be considered. So if you do this due diligence of looking at lifestyle choices, current medications, along with iron levels, we actually remove a whole lot of patients that need medication therapy, because it's the medication therapy which is also comes with, it's a double-edged sword. It comes with side effects. And like what we found, when I was in training, dopamine agonists were first line. I mean, we were prescribing that immediately once we heard restless legs. They met the 4 criteria. Boom, boom, boom. Check, check, check. We looked at the medication list to make sure that there wasn't any major offenders. We would check a ferritin level, but the first line was dopamine agonists. And unfortunately, now we know, and that's how science works, is that as we do more data, more long term, because the FDA approval for these medications were done in short term therapy. And when you look at it long term, we found augmentation is such an issue that it seems to take away from the benefit. And then it leaves this residual augmentation that worsens your symptoms. And I've mentioned augmentation so often, so let me kind of go in a little bit more and describe what that is. It's a worsening of your symptoms. It can occur either now earlier in the daytime. It could be that your periods of normalcy or normal feeling actually reduces, so you seem to have more attacks more frequently. It occurs earlier in the day, or it starts moving to other body parts, like from your legs to your arms and so on. And so that augmentation is a bad side effect, and it does leave us kind of at risk of this persisting. But it also leads to a lot of behavioral changes that we weren't aware of, because dopamine, don't forget, is a happy drug. I mean, you get one hit of that, and we don't realize this is how much it has an effect on our behavior. Now, if we're not advising the patient uh, to watch out for these behavioral changes, they wouldn't know any better. And some of it is just, are they online shopping more than they used to? Are they so focused in a hobby now that they've left other things to the side, to the detriment of their family or their own health, or something like a real what's it called, a focus, an abnormal focus on a new habit or a new gambling. Online gambling is another one as well. So we find patients tend to have this, and if you don't question them on this, it might go unnoticed, and then you continue to prescribe that, and that habit continues, and it normalizes in their lives, and it can ruin relationships. So that's why we try to avoid it. At the new guidelines by the American Academy of Sleep Medicine, the draft guidelines came out a few months ago, and it does talk about using other drugs as a first line. And that kind of brings me to the second part of this, which is to consider things like gabapentin enacarbal, and even Lyrica or pregabalin as first line therapies. And previously, we would look at opioids as a third, fourth line medication, but now it's been brought up to at least a second line medication. Generally, again, if you do your due diligence on the front end with the behavioral intervention, checking the medication list, checking the iron level, you reduce a whole lot of patients that need the medication. Then for those patients who need the medication, then the first line is gabapentin enacarbal, and along with Lyrica or pregabalin. I think you would cover most patients needed. And even with these drugs as well, you can switch from one to the other within the first three that I mentioned, and try different versions of that, like the gabapentin enacarbal, and you can switch back and forth to see which one works best. Unless, of course, they have a bad reaction to it, then you want to consider moving to a low dose opioid. Now, everyone, when they hear opioid, because the last 10 years, everyone goes, holy crap, no. What we find is when opioid is prescribed for things like restless legs, the addictive nature of this drug isn't really as strong. It's usually when it's prescribed for pain that addictiveness of that medication is really strong. And they use different things like buprenorphine along with naloxone as a treatment as well for some of these medications. Again, these heavy duty drugs, or what we consider heavy duty drugs like opioids and so on, really are needed when we need to treat augmentation from patients who are given dopamine agonists. So we find that it's a lot easier to manage restless legs when we don't trigger augmentation. Man, I can keep talking. I will shut up and let you lead the way now.
You answered a lot of my questions. That was a good rant. So the only thing you didn't touch on in like lifestyle choices would be exercise or movement. I know when people
Mhm.
often are having a bout of restless leg syndrome, they want to move. Some of them even get up and pace and just do something helps. But is there like any correlation between being, I know you mentioned being sedentary is when you feel it, but just being more active in general? Can that be beneficial?
Yes, and I'm glad you brought that up. And it's my bad for not mentioning that some of the lifestyle changes. Activity, being more active, definitely helps. It reduces some of your nighttime symptoms as well. So we definitely do find that. Now, whether that itself will cure you, it's a good adjunct in addition to everything else you're doing. But yes, so definitely, I think staying more active and so on definitely does help. It reduces your nighttime symptoms. Some people like warm baths, like foot baths as well, to kind of calm the nerves down, so to speak. But yeah, exercise is a great option as well as an adjunct to therapy.
Has there been any like research or looking at like compression garments for helping that, or does that not do much?
It does. There's actually something newer now that is waiting for more evidence. Is peroneal nerve stimulators. So these are nerve stimulators that helps calm the nerves down, and it's slowly getting. I think they were approved FDA wise, but they're getting state by state approval, so they're going through that. So nerve stimulators are PERONEAL. Nerve stimulators are coming into the marketplace now that might be helpful for some of these patients who have really severe symptoms and are not amenable to the behavioral interventions we talked about. and many drugs or the medications they've tried have not worked as well. So definitely some of these nerve stimulators may help. Compression does help, and so on, especially if that's something that you've been dealing with for a while and you have a little bit of swelling in your legs and so on. Again, whether it'll work for every patient is hard to say. So it's worth a try to see whether it does improve that. One thing you don't want is someone trying that for too long and saying, "Oh, it didn't work, so I'm just going to stop." Some of these things require, like, you should definitely try exercising and you should definitely move. But if it doesn't work 100%, it doesn't mean that you should discard it. You should kind of keep at it because it's a good habit to have. Even with the stocking compressions, it might help you. It may not help you at all. And if it doesn't, then you need to figure out what else to do. If it does help you, then what's stopping you from continuing using it? Make sure it's not too tight. That kind of leaves issues and so on with your skin and so on. But I think apart from that, it seems to work for some patients.
I'm guessing the nerve stimulation is some type of external device.
Yes, it is. It's an external. It's a little leg brace that you wear that fits around, and you switch it on, and it kind of delivers these sort of electrical conduction that helps with your nerves and
Sure.
calms the legs down.
So we talked about some of the health benefits and lifestyle factors you can change. Is there any recommendations in diet nutrition? Obviously, if people are diabetic, just cleaning up your diet is going to help a bit. But
Yeah, I mean, I think a healthy diet, it comes down to, again, if you have low iron levels as well, to get that checked out and make sure that you are supplementing that in your meals and so on long term. But generally, no, we've not found any significant, and the guidelines as well doesn't really have any strong recommendations for changes in your diet that will have, again, because the guidelines require a very high level of evidence. It doesn't mean that some changes in your diet will not help. It's just that we don't have enough evidence to make a recommendation. So for the common sense things, obviously, healthy diets work. Avoid things that have a stimulant effect, like caffeine or teas and so on, that might trigger your legs. And you want to make sure that if you have iron deficiency, maybe increase your iron intake through your meals that you have. But yeah, I think keep with a general good healthy diet.
I know you mentioned it earlier, but I'll just kind of highlight again. You also talked about tobacco use and alcohol. I'm presuming
Mhm.
can overabundance can probably be a correlational as well.
Yes, and that's because of the stimulatory effect they have, and that's why stress in life. For me, for example, I know my restless legs were an issue when I was facing like an exam or a board exam or at a big project that was due. I noticed that my wife would give me feedback. She said, I noticed you had trouble falling asleep, and you kept running in your sleep. And the other trigger for me was alcohol as well. So with my wife, I get constant feedback. So I definitely know that's a trigger. But yeah, so I definitely, if you have that as an issue, I mean, definitely looking into smoking and alcohol and so on, along with caffeine intake, is helpful. And then sticking with a good exercise plan as well.
Yeah, because I'm sure I've met other people that have restless leg syndrome, but two people I can think off the top of my head. One was my grandmother years ago, and she was older and on all sorts of medication and probably had a low iron. So that was probably her issues. And she also had
Mhm.
neurological things later, like dementia. But my other friend is younger than me, but he smokes a lot. So I'm like,
Mhm.
That's probably why."
Yeah, and again, we won't know until they stop and switch, and then again, checking the iron levels to make sure, because again, because smoking is such a hard habit to kick, we don't want to say, well, it has to be the smoking, you need to stop. We still have to do our due diligence to make sure it's not a medication side effect. Neither is it a low iron level. Now, most guys should not have a low iron level. Women tend to have that because of the menstrual cycle and so on. So that's why women tend to also be a little predisposed to this, along with during pregnancy as well.
Sure. So if someone was recently diagnosed with restless leg syndrome, what advice would you give them?
Don't start medications immediately, unless, of course, it's severe. Make sure that you have your physician or whoever's prescribing it go through your medication list to look for any trigger factors there. Order an iron panel, and you're looking for two specific levels: serum ferritin level, and you're looking for transferrin saturation. And you want the serum ferritin to be 100 nanograms ng slash ml, nanograms per deciliter. And you want the transferrin saturation to be above 20%. So make sure that's done. They check the medications you're on as well to make sure there's no side effect from that. And then before exploring treatment options, and you want to avoid things like dopamine agonists, and the common trade names are Mirapex for pramipexole. There is Requip or Ropinirole, and then there's the Horizon patches, which is the Rotigotine. So, these are all dopamine agonist drugs. So you want to avoid that if that's the first line that your physicians are prescribing, and let them know that, hey, they may want to consider gabapentin or gabapentin narcobil or pregabalin or Lyrica as treatment options. So, looking at those medications as first line would be the first thing that you do if medications are considered.
So, is there any new research coming out on it that you want to share, or did we cover everything?
The research now is a lot on the effects of like opioids and things like the buprenorphine with naloxone, and how that seems to work for this patient population that were previously, because we've been treating a lot of patients with dopamine agonists. There's a lot of augmentation out there, so there's a lot of research going into the third line or second line therapy or third line therapy, so that patients can get relief of their legs, since a lot of it is not amenable to regular medications. So a lot of the drugs now are coming. A lot of the research is looking at that. One thing I want to impress upon everyone is looking as well, making sure that even though restless legs, and everyone is going to say this, restless legs does not need a sleep study, which is true, because restless legs is a awaken or a while you're awake phenomenon, not a sleep phenomenon specifically. Things like sleep disorders, such as sleep apnea, may trigger worsening restless legs. So, to ensure as well that you don't have any risk factors for that, that may warrant a sleep study in addition to the rest of the workup being done. Because I mentioned that earlier, and I forgot to mention that as a rule out factor as well, not just behavioral intervention, looking at medication as well. Make sure there's no other secondary or primary sleep disorder that may be triggering a hyperstimulated state, because a lot of sleep disruption leads to hyperstimulation or stress levels, and that triggers your restlessness in your legs.
So, do you want to mention your website again?
Sleep.com, spelled like my patient said, crazily spelled SLIIP.com. I was trying to keep up a smile without crying on the inside when she kept saying that. But yeah, so just look us up. We're happy to help. Reach out to us. Again, we'll be happy to kind of work with you all to kind of get you off the dopamine agonist or avoid needing to be on medications at all. Because sleep is such a thing that we now know that it's a core function of how we are as a being. I mean, the more we learn, the more we understand that if you don't wake up refreshed or you don't get a good night of sleep, the rest of the day is going to be, it's kind of like literally waking up on the wrong side of bed. I mean, you really are. With a sleep issue, you will wake up on the wrong side of bed every day, and it's hard to deal with. So definitely making sure that you seek help if this is affecting your quality of life, making sure that you don't just brush it off. You can do a lot of due diligence on your own. Just look at the medication list. Just see, oh, what did I just start recently? Ask yourself that. What did I change in my medication or my diet? And that might be a helpful start to kind of treat yourself, so to speak, because it may just be, oh yeah, I just started that anti-allergy medication because it's been flaring up my allergies. And that might be it. So I know I went off course with that conversation, but I just wanted to make sure I hammered home that point.
You're fine. We're only a half hour into this. I think we did pretty good today. Well, thank you for joining me, and hopefully we can find something else to talk about in the future.
Yes, I still need to be. I need to beat whoever's on the first of your podcast guests. So looking
In
forward
all
to
fairness, he's a physical therapist we work with a lot, so he's got a lot to talk about.
that. Well, excellent. Well, if I can help in any way with your patients and your next podcast, let me know. Thank you again.